Good evening. This is a meeting of the Baltimore City Council Health, Environment, and Technology Committee. The hearing is now called to order. I am Councilwoman Danielle McCray, representing the 2nd District, and I am the chair of the committee. In attendance, we have Councilman John Bullock.
Thank you, Madam Chair.
From the 9th District. Thank you, sir. We also have Councilman Mark Conway from the 4th District.
Thank you, Madam Chair.
We have Councilman Ryan Dorsey from the 3rd District. We have Councilwoman Felicia Porter from the 10th District.
Thank you, Madam Chair.
Councilman James Torrance from the 7th District. And Councilman Isaac Yitzi Schleifer from the 5th District. We are also joined Thank you, sir. We are also joined by other members, other council members, including Councilman Eric Costello from the 11th District.
Thank you, Madam Chair.
Thank you. And Councilwoman Odette Ramos from the 14th District.
Thank you, Madam Chair. Good afternoon.
It's great to see you here. So also in attendance, we have Matthew Peters, staff to the committee. From the mayor's office, we have Nina Themelis.
Thank you, Madam Chair.
From the council president's office, we have Matthew Stegman on the line.
Thank you, Madam Chair.
And before we get started, I'm just going to go over just a few ground rules. I'm just going to ask everybody to please stay muted until you are recognized by the chair. Also, please mute yourself when you are speaking. Before you speak, please identify yourself, the agency or organization that you are with, and your position. Please speak slowly and clearly. After you have finished speaking, please mute yourself again until you are recognized by the chair. And last, for the committee members, we're just specifically asking you and city agency officials to please keep your video on for the duration of the hearing, unless there are technical issues preventing you from doing so. This is just for transparency, so the members of the public know that we are listening and that we are paying close attention. And for the members of the public, there will be an opportunity for public testimony. You will be provided 2 minutes each for testimony. Today, we are here for City Council Resolution 21-0003R, informational hearing, Baltimore's COVID-19 vaccination plan, for the purpose of inviting representatives from the Baltimore City Health Department, Baltimore's healthcare community, and other interested parties before the Baltimore City Council to discuss Baltimore's COVID-19 vaccination plan. The hearing format for today is as follows. We're going to have brief remarks from the sponsor of the resolution. There will be a presentation from our health department, and members of our health community will speak on topics regarding the vaccination plan. That will be followed by questions from committee members, and then we will have public testimony. We all know the impact that COVID continues to have on our city. We have lost over 717 members of our community and have seen devastating economic impacts. We are fortunate that vaccines have been developed, but it is critical that we communicate openly about our plans to issue the vaccine to our residents. This is why I put in this resolution for this important hearing. There have been many questions within our communities around the COVID-19 vaccine and vaccination plan, and that's why we're here today. Questions largely around the safety and efficacy of the vaccine distribution, vaccine hesitancy, equity, and how we are going to communicate and engage all communities across our city. This hearing is to provide members of the public with up-to-date factual information so they can make an informed decision regarding this vaccine. We're going to move straight into hearing from our panelists from the City Health Department and the healthcare community. Committee members, I am asking that you please hold your questions until all of the presenters have finished. Just to let you know who will be presenting, it will be our commissioner, Dr. Letitia Jaraza with the Baltimore City Health Department. We'll have Dr. Sharita Hill Golden from Johns Hopkins Medicine. We will also have Dr. Michelle Gordine from the University of Maryland Medical System, and Dr. Destiny Simone Ramjohn from CareFirst. And at this time, Dr. Jarazda, you may start your presentation. Thank you.
Thank you, Madam Chair. Am I to refer to your team for slides, or should I plan to present from my screen?
We're actually going to give you access, and I think we're working on that for you right now. Thank you. Okay, and Dr. Jarazda, do you have access?
It looks like it let me double check here.
Okay.
Um, I have to give my computer permissions. So I actually may have to log off and then log back on in order for that to work.
Okay, so what we're going to do, we're going to take about 15 seconds and we're going to do it from now in. Thanks for your patience.
Thank you. Great, thank you. So thank you again, Madam Chair, for introducing this resolution. Thank you all for the opportunity to talk about the work that the Baltimore City Health Department is doing around COVID-19 vaccinations. And I also just want to thank my partners who are on this call. I will talk about this some throughout the presentation, but we cannot do this work alone at the Health Department and rely on strong partnerships with our healthcare facilities and with our insurers to get this work done. Next slide. So again, the information that's presented is up to date as of yesterday. And I put this disclaimer side because I will be talking a little bit, as Madam Chair mentioned, about the vaccine and efficacy. And all of this is based on data that we have as of now. We fully recognize there are things that we're still learning about coronavirus. There are still things that we're learning about the vaccine. Next slide. So as a brief agenda, I do want to share some general information on the COVID-19 vaccines. I'll provide some background, discuss common side effects and some frequently asked questions. I'll also talk a little bit about prioritization of vaccine allocation, how it was developed here in the city, and where we are and who's in what phases. And then lastly, I'll talk about our approach to vaccine dissemination and using partnerships to really scale up vaccine dissemination across the city. Next slide. Great. So just to provide a little bit of background, in December of 2020, both pharmaceutical companies, Pfizer and Moderna, were granted something called an emergency use authorization by the FDA. This means that the vaccines that they produced had been tested and were considered safe and effective for general public intake. Next slide. So how do these vaccines work? They're both what we call mRNA vaccines. The mRNA vaccine helps our body develop something called immunity, or helps our body's ability to fight off an infection in the event that we were exposed to the coronavirus. They do not change our DNA, they do not cause disease, and they are not a weakened version of the COVID-19 virus. Next slide. So how effective are these vaccines? They both have over 94% efficacy. We know that, again, that's relatively high when you think about how effective a vaccine is compared to the flu vaccine, for instance. And we know that vaccine efficacy is noted in the case of Pfizer about 7 days after that second dose and about 2 weeks after the second dose in the Moderna vaccine. What we also know is that they're highly effective in preventing severe outcomes from COVID-19. So in the event that you contract the coronavirus, ideally your hospitalization, if at all, is shorter and your outcomes and your illness is much less severe. We've seen that the Pfizer vaccine is equally protective across age, racial, and ethnic groups. The Moderna vaccine appears to be slightly less protective in individuals over 65, but is equally protective when we look at race and ethnic groups. Next slide. So again, how many times do we have to get the vaccine? Both of them are 2-dose vaccines. You have to get both doses to get that level of efficacy, that 94% effectiveness. For Pfizer, those doses are given 3 weeks apart, and for Moderna, they're given 4 weeks apart. Next slide. So in summary, again, both vaccines are given two doses in 2 doses. Pfizer is 3 weeks apart, Moderna is 4 weeks apart. Pfizer is the vaccine that is approved for people as young as 16, while Moderna is approved for individuals 18 and up. We know that they both have over 94% efficacy. They both reduce the risk of having a symptomatic infection or having an infection where you're experiencing the symptoms of coronavirus. And they both reduce having severe disease if you do get the coronavirus. Next slide. We also know that for the Pfizer vaccine, there was no difference noted across age, ethnicity, and chronic conditions. For Moderna, there was no difference in efficacy noted across ethnicity and chronic conditions. So talking a little bit about side effects. After getting the vaccine, we do know that some people experience side effects and that they are common to vaccines generally. And they're usually pretty mild or moderate and go away within 1 to 2 days of the vaccine. Some of the most common side effects are pain, redness, and swelling at the injection sites. It was noted that this was less severe in older adults, but we also see fatigue, headache, muscle pain, joint pain, fever, and lymph node swelling. These side effects are reported more commonly after the second dose. Another thing that's important to note is, as many have probably heard, that in rare instances, people can have what's called an anaphylactic reaction to the vaccine, meaning a severe allergic reaction in which you may be unable to breathe. And what we know is that it could be related to some of the ingredients within the vaccine. And so certainly at our vaccination sites, and I believe at many of the healthcare sites that are providing vaccine, we do review these list of allergens, possible allergens, with individuals who are coming in to get vaccinated, again, to ensure that there isn't a history of an allergic reaction to these components. But if you do have a history of an allergic reaction, that is the contraindication to getting the vaccine. Next slide. So shifting a bit to talk about some of the frequently asked questions, I think it's important that we use this opportunity to try to dispel myths, but also be accurate with what we do know and acknowledge there are still things that we're learning. So first, FAQ that we receive: will COVID-19 vaccines give you COVID-19? So as I mentioned earlier, neither vaccine or any of the vaccines that are currently being developed use what's called live virus as a component of their vaccine. So they're not actually giving you COVID-19. Both of these vaccines, Pfizer and Moderna, use mRNA. So they essentially trigger your body's immune system to create something called antibodies that in the event of being exposed to coronavirus, those antibodies would recognize it and begin to fight it off. Next slide. So next, FAQ, should people who have gotten sick with COVID-19 still get the vaccine? Yes, in short. The vaccine, we know, does produce a much longer and stronger immunity against COVID-19 than getting the actual disease. We don't know how long actually you're protected after you have had the disease. So again, the vaccine helps us to know that there's going to be some level of prolonged immunity or protection against the disease. We know that the actual natural immunity does vary from person to person. Some people, may experience it for 3 months. Some people may have antibodies beyond that point. But again, the vaccine is going to trigger a much stronger protective response. Next slide. Next question, can getting vaccinated help prevent you from getting sick with COVID-19? So again, there's no way to know how you will be affected if you get COVID-19. We've seen many people without underlying health conditions become severely ill, and certainly some with underlying health conditions that become ill but do recover. What we do know is that the COVID-19 vaccine does help protect you by, again, starting up that immune response without having to experience the actual disease. So your body is prepared to fight off the disease in case you're exposed to it without having to actually get the virus. If I get a vaccine, do I still need to wear a mask? So we are hearing this question quite a bit, and the answer is yes. So until we've reached something called herd immunity, meaning enough people are protected against the virus or have the ability to fight off the virus in the event that they're exposed, we will still need to wear masks. We'll still need to avoid large indoor gatherings. We'll still need to maintain physical distance, even after getting both doses of the vaccines. So again, even though they're effective, they're not 100% effective. They're 94 to 95% effective. So there will be some people who won't be completely immune. Again, it's also unclear if getting immunized protects you from transmitting the disease. We know that currently up to 50% of people are asymptomatic, meaning they have no symptoms when they spread coronavirus to other people. We don't know how the vaccine affects that, right? Are you going to be still an asymptomatic carrier even though you've been vaccinated? So again, it's going to be really important that we get as many people vaccinated as possible so that we can achieve that herd immunity. So what is our goal? Shifting gears a little bit to talk about our strategy and vaccine dissemination. Our goal is to plan and implement a coherent, collaborative, and equitable approach to scaling up COVID-19 vaccination here in Baltimore City. So this is going to be right now one of the most challenging times that we've faced in the pandemic. We've implemented, again, many mitigation strategies and what we call non-pharmaceutical interventions. So that's the restrictions that we put in place at the city level. But we're finding that there's such widespread community transmission that it is harder and harder to control the spread of COVID-19. Rapid, broad vaccination is going to be one of the most important tools we have to end the pandemic and get back to some sense of normalcy. And the difference between how fast or how quickly we can do this really will be measured in lives saved. So we have a need to scale up vaccinations, and this is pulled directly from the Maryland Department of Health's vaccination schema on who is prioritized. What we know is that currently we're in phase 1C at the state level. 1A consisted obviously of healthcare workers, residents of long-term care facilities, first responders, and some public safety members. And that's about 10,000 people. And again, this is a rough estimate based on individuals who both live and work here in Baltimore City. 1B is expanded to include assisted living settings as well as other congregate settings, adults over the age of 75, education and continuity of government, while 1C expanded the priority group to adults over the age of 65 and other essential workers. And again, looking at phase 1B, that's about 60,000 people, and 1C is about 80,000 people. Next slide. So we know that given just the sheer volume of individuals in these priority groups, that we're going to have to take a multi-level, multi-partner approach. We know that mass vaccination pods are being stood up. We have one that's city supported at Baltimore City Community College. And recently the state announced the standing up of other mass vaccination sites. And this will be essential for reaching large numbers within the population. We also know that our hospital partners are doing vaccines, not just for their staff, but they're also beginning to vaccinate those in priority groups as well. So these models are absolutely essential and will support vaccinating large groups of people. We also know that there's going to be a need for just a standard healthcare model. So being able to go to your physician to get vaccinated, being able to go to your pharmacy to get vaccinated. And that includes our federally qualified health centers who are also beginning to vaccinate, again, with a focus on those priority groups. Lastly, we know that there's a need to go to where people are. So we recognize that there's a population that will be challenged to get to a mobile location. Or get to a mass mass vaccination site, there's a population that will be challenged. Potentially, they don't have access to healthcare, and so it'll be hard for them to get to a federally qualified health center, or maybe they have poor mobility. And that's where the mobile response teams come into play. And this will be a mix of support from our hospital and healthcare partners at federally qualified health centers, as well as the health department, in partnership with our community-based organizations we know are trusted messengers and trusted to help with care coordination and getting individuals vaccinated. Next slide. So some overarching strategic objectives. Again, we talked about having an equitable and collaborative approach to getting residents here in the city vaccinated. We've set a very lofty goal or objective of 80% of Baltimore residents being vaccinated by February 2022. Again, much of this does hinge on supply. So recognizing that hopefully in the coming months, supply will open up. And we'll begin to be able to meet all of the demand that we're seeing. We know another important part of our strategy is how we communicate and educate our city residents on COVID-19 vaccines. We have to be transparent again in what we know and what we don't know, what we're still learning. And then we have to be able to help and support them with registering for appointments. And then lastly, really being transparent in how we're monitoring the data. So planning to launch a public-facing dashboard that shares where we are in the vaccination process. Next slide. So this is pulled again from our website and just gives you a further breakdown of who is in what phase. Again, we're currently in phase 1C, and we continue to vaccinate individuals in 1A and 1B. Next slide. So vaccine efforts to date from the health department. In December of last year, we did release our prioritization guidance, and this was developed in partnership with MDH, so guidance that they had put out, but also looking very closely at the CDC's guidance around how we should prioritize individuals in a way that is equitable and considers access. Likewise, we're working with the Mayor's Office of Emergency Management in coordination and prioritization of our city workforce. Have had some initial meetings with agency leadership to explain the prioritization, to explain the COVID-19 vaccine and what we know so far. We've talked and we've held telephonic town halls for our older adults, again, providing education on the COVID vaccine, and we'll continue to hold those town halls throughout. We've expanded our MAP call center, our Maryland Access Point, last week, and this allows for older adults who may not have access to a computer or may have trouble navigating the registration site. We pre-register those folks for the vaccine so that when appointments become available, we're able to easily call back and get them scheduled for an appointment. We also launched a community engagement work group that will help direct our COVID vaccine messaging, and this is inclusive of 60 community groups. We launched our COVID-19 citywide task force, again, to inform the implementation of this strategy and ensuring that we have a focus on high risk and vulnerable populations. Next slide. We've been vaccinating individuals in phases 1A and 1B, and I should add 1C as well, since that opened up earlier this week. We established our initial pod or point of dispensing for mass vaccination on January 5th and transitioned from our original location at Port Covington to Baltimore City Community College earlier this week. As of now, and actually a quick update, as of this evening, we've given 7,044 vaccines so far have been disseminated from the Baltimore City Health Department's vaccine site. We will begin providing second doses of the vaccine to our staff this week and begin providing additional second doses to those that were vaccinated through our pod next week. As Governor Hogan announced yesterday, there is a plan to establish additional mass vaccination sites here in the city at M&T Bank Stadium and the Convention Center field hospital. Additionally, we are working with our hospital partners, many of whom we've already begun to allocate vaccines to so that they can focus on some of the priority groups, specifically older adults. We've also seen where educators have been able to partner with Hopkins to be vaccinated. We're also working with our federally qualified health centers on vaccinations as well. Specifically asking that they be allocated additional doses so that they can start to focus on older adults in the community too. Next slide. And that completes my presentation.
Dr. Jaraza, I want to thank you for this presentation. I also want to thank you on your leadership throughout this entire pandemic. We truly appreciate you. At this time, I'm going to move to Bill Ward. Bill Ward is the communication lead for the private-public partnership, and he's going to speak briefly for about 1 to 2 minutes. Thank you.
Thank you, and I will be brief. The public-private partnership was initially created at the onset of the pandemic. And while a lot of the originators are on this call and in this meeting from Hopkins and UMS and CareFirst in the city, it's important to note that a lot of partners have joined in where they could along the way. It's been a long uphill battle. The goal for this partnership is really to be leveraging the collective strength and extensive resources of all of these entities to make sure that we have and we continue to bring and deliver the best tools, communication support, innovations, access to medical care across all of our neighborhoods to the underserved, to everyone that needs support through this pandemic. Ultimately, the P3 is the culmination of the best in medical science and care in the world, and we have the benefit of it being here in our backyard. So moving forward, we are focused on creating trust across the community in the COVID vaccine and doing everything that we can collectively to make sure that we can be consistent and factual about the vaccine and how to help deliver that across the Baltimore City community. And with that, I'll turn it back over to Councilwoman.
Thank you, Mr. Ward. So I just want to acknowledge a few additional council members who have joined the hearing. We have Councilmember Antonio Glover representing the 13th District. We also have Councilman Christopher Burnett representing the 8th District. At this time, we're going to move to Dr. Sharita Hill-Golden with Johns Hopkins Medicine.
All right, so thank you, Councilwoman McCray, for inviting me. And I'm going to talk about what we've been doing at Johns Hopkins Medicine, specifically focused on vaccine equity and sort of our role in that as one of the P3 partners. So we've really focused in two areas. One, so I'm Sharita Golden, Vice President and Chief Diversity Officer for Johns Hopkins Medicine, and I'm also a professor. I'm in the School of Medicine, so I was a diabetes clinician for about 25 years before I took over our systems health equity operations. And so, our office really focuses on equity issues in two groups: our employees as well as our patients. So because healthcare workers were the first group that were allocated to receive the vaccine, we wanted to make sure that it wasn't just our doctors and nurses in our health system that were receiving the vaccine, but that also all of the essential workers that keep our hospital running, so environmental services, patient transportation, security, dietary staff, facilities, that we made a conscious decision to include all of those individuals in our healthcare workforce. And so one of the things that we recognized, though, is that the sign-up system that we had created through MyChart, which is in our electronic medical record, that would give our healthcare workers access to the vaccine form, that was an electronic way of people having access. And some of those frontline workers either didn't have their own computers at work, or they were very busy out doing their jobs during the day, so weren't necessarily sitting in front of a computer to have this done. And many of them didn't have these MyChart accounts that we were using to register people activated. So there were several things that we did to address that from an equity standpoint. we partnered with our nursing office of clinical practice, as well as the chair of our Johns Hopkins Hospital Diversity Council and Dr. Katie O'Connor in our Incident Command Center to set up MyChart activation stations. So we have MyChart activation stations set up at Johns Hopkins Hospital and Bayview Hospital in the city, as well as 2 of our other hospitals in the National Capital Region. But that allows employees to have someone actually walk them through the process of signing up for the MyChart and then signing up for the vaccine lottery. And then once they even get the notice about the lottery, we will walk them through signing up for the actual vaccine appointment, because we wanted to remove any technology barriers that we could. The other thing that we heard from our frontline staff, many of the staff I mentioned to you in our system are African American and Latinx, and they said they wanted to hear from physicians who looked like them. They wanted to hear about our vaccine experience, and they also wanted us to answer questions for them about the vaccine. So we are fortunate that we have several infectious disease physicians at Hopkins who are Black and Latinx, and they actually did a video recording talking about the contributors to COVID-19 disparities, as well as a presentation on the vaccine science and layman's terms. So those videos are now sitting on our internal portal, and they're also available to the public and accessible on our YouTube channel. So those were things that they wanted to hear that were important. We also did a video on the demographics of the Pfizer and Moderna trials, because they also wanted to know how many Black and Brown individuals participated. And then the last thing we did was had a series of virtual Zoom town halls with our employees to answer their questions directly. And again, we were very fortunate that a lot of our Black and Brown physicians stepped up to do these early morning hours, late morning hours, so that we can answer our employees' questions. And we've been going in person to huddles. So that's how we've approached our employees. And quite frankly, many of our employees at both Hopkins and Bayview live in the zip codes around our hospital. So they are our community. So we felt like we were also reaching our community. And then from the standpoint of our patients, now that the state has rolled out patient vaccine program, and now those 65 and over, what we've been doing is, so for our patients who are patients in our system who do not have active MyChart accounts, again, the way that they can go into the vaccine lottery, we have reached out to those patients who don't have MyChart accounts specifically by calling them and letting them know that they are eligible. So when their ticket comes up, they get a phone call and their appointment can be set up. The other thing that we have done is we have specific clinics, both at Johns Hopkins Hospital and Bayview, that take care of the underserved. And so we have worked with our IT department. And so they have been able to run a report for us of who are the patients in those clinics who are 65 and over. And we've identified about 6,000 of them. And so what we are doing is we are seeing, for those who don't have an active MyChart account, we're reaching out to them again by phone. When their tickets come up, to let them know you've been selected for the vaccine. We will set up the appointment for you and make sure you can get here to get your vaccine. So those are some very grassroots and hands-on efforts. And one of the other things we've had to be mindful of is, because it takes more effort to reach those communities, we've had to make sure that we set aside some of our vaccine supply for those individuals, so that those who can easily get access through MyChart and use the computer, don't deplete the resources while we're having to spend time. So we're trying to make sure we think about, setting aside doses for those that take a little more time to reach, but who also want the vaccine. So those are the things that we've had to stand all that up in the last week and a half, because, as you all know, it was the beginning of last week that we started vaccinating patients in the state. So that's been stood up in the last week and a half. And then moving forward, we're planning to partner with the city on supporting vaccinations in several of our senior complexes in the city, sort of activating our GO teams to go directly to the senior sites to assist with vaccination, like we've done with some of the testing in other areas. And then we are also planning to launch a website and a phone line for our non-Johns Hopkins medicine patients to be able to register for the vaccine selection process. And then the final thing that we're doing is we're really partnering, and Councilwoman McCray, Ms. Porter, there's several on this call that are part of our larger sort of academic community partnership around community education around COVID-19. And this afternoon, we were very fortunate to have Dr. Kismikia Corbett, who is, an African-American physician scientist who is really behind the vaccine technology that has gone into the Moderna vaccine, did a really phenomenal community presentation this afternoon where we had about 1,300 people on the webinar. So we are, really trying to utilize our resources to really support and reach out to everyone. So, so I'll turn it back over to Councilwoman McCray, and we look forward to continuing to collaborate.
Dr. Golden, thank you so much for being here and for sharing that information. I'm going to get to the next panelist. Before I do so, I do want to make sure that I acknowledge our Vice President of the Baltimore City Council, Sharon Green Middleton. She has joined us. She does represent, I want to make sure that I get this right, she does represent the 6th District of Baltimore City. So thank you so much for joining us today, Vice President. The next panelist that we're going to speak with is Dr. Michelle Gordine.
Thank you very much, Madam Chair. My name is Dr. Michelle Gordine. I am the Interim Chief Medical Officer and Senior Vice President at the University of Maryland Medical System, and it's a pleasure to be with you this afternoon. I am going to focus on our efforts in addressing vaccine hesitancy in our communities. At the University of Maryland Medical System, across our 13 hospitals, including those in Baltimore, we're very cognizant and concerned about the disparate impact that COVID has had on Black and Brown communities. We know that Black people are almost 1.5 times more likely to be infected with COVID, and the risk for Latinx populations is almost twice as high. People in these communities who do contract COVID are nearly 4 times more likely to require hospitalization and nearly 3 times more likely to die. Health comorbidities like heart and lung disease, obesity, diabetes, high blood pressure, and others are linked to COVID complications, and these health issues affect Black people at a higher rate. Systemic health and social inequities put communities of color at a higher risk of severe COVID disease and death. We know that COVID vaccines are the way out of this pandemic, and we're deeply committed to ensuring that our communities have the information they need to make informed decisions about getting the vaccine. But we also understand that there is hesitancy, and we understand that that hesitancy is really grounded in our history in this country. History of harmful research, history of exposure to unnecessary risks, to not fully explaining research, and to treating African Americans as experiments without their consent. And so we believe that we need to give people the time and the information that they need in order to make their own choice about getting the vaccine. Admittedly, I hope that we all get the vaccine, but we need to allow people the opportunity to ask questions and have all of their concerns dispelled. And so we are focused on providing that information without the recipient feeling like they are pressured to hurry up and get the vaccine. We've done a number of things in order to provide information to a number of audiences in a number of settings, and I'd just like to list a few of those for you. We reached thousands of individuals with our virtual Finding Hope Town Hall that was held on Martin Luther King Day. The president and CEO, Mohan Santha, was the host, and Dr. Freeman Rabowski from UMBC was the moderator. The town hall featured myself and other physicians of color as expert speakers. Several hundred individuals watched our Let's Talk community conversations featuring physicians of color from our community to speak directly to community concerns. Our targeted vaccine information has been translated into Spanish to reach our Latinx population. We've held a series of listening sessions and COVID information sessions with trusted partners across our communities in West Baltimore, including our Community Advisory Council, faith leaders, and elected officials. Similar outreach is occurring across all the communities in Maryland where our hospitals are located across the state to spread the word about the importance of the vaccine. University of Maryland Medical Center has provided vaccination for a number of faith leaders who are community ambassadors and partners, because we understand the importance of vaccinating individuals who are seen as trusted community leaders and messengers. And this helps to communicate the importance of the vaccine within their congregations and their networks. A number of West Baltimore congregations are represented in this effort, including Trinity Baptist Church, Bethel AME Church, and New Psalmist Baptist Church, as well as the Ark Church. This is in addition to the efforts to educate our own staff, many of whom live in Baltimore City and therefore are part of this community that we serve. As we know, the vaccine started with frontline workers, the healthcare heroes at the medical center, and other hospitals throughout the city. We work tirelessly to provide educational materials, highlight vaccine champions to lead by example. We also made a point of providing one-to-one communication where needed in our hospital settings to individuals who wanted some additional information and wanted an opportunity to digest that information and discuss their concerns with individuals who they trusted, who were co-workers in the hospital setting. Our internal and external efforts over the first 6 weeks of vaccination are a good start, but it's going to take a concerted effort by the entire healthcare community. Our experience so far points to the necessity to develop one thing, and that is trust. And we understand that that trust takes time to develop. The serious and very real issues of structural racism, health equity, and mistrust of the healthcare system are topics that we must confront and that we must address and that we must solve for the long-term health of our community. We are all committed to that, no one more than me. I'd like to suggest that the COVID-19 vaccine is an opportunity to perhaps make greater strides in developing that needed trust more than any other health issue that we've faced. I am a scientist, I'm a physician, I'm a former local and state health officer, I'm an advocate for health equity, I'm a champion for my patients, I'm a mother, I'm a wife, I'm a daughter, and I'm a Black female. And I can tell you that vaccination is the answer. And I know that because I've studied the science. I made a point of studying the science behind this vaccine because I knew that my family was going to call, my friends were going to call, my church members were going to call, and I wanted to be able to be as transparent as possible and to present the best information that I knew. And I felt that if I was comfortable in telling my mother to get the vaccine, which I have done, I'm comfortable in telling everyone else that it's important to get this vaccine because I would never put my mother in harm's way. And so I'm committed to helping us to pull our community together. And I believe that together, vaccination is the one tool that will allow us to get out of this pandemic. This is the only tool that we have, and it really is our greatest hope. I believe that we need to continue to work together and to collaborate together in order to address respectfully and transparently and patiently all the questions that individuals may have, to meet people where they are and to make sure that we are willing to provide information to people so that they can make decisions in their own time. We've told our employees and our health team members at our hospitals that although phase 1A was rolled out first and we focused on our healthcare providers and our healthcare workers, that as we move throughout the various phases, if people decide later that they have enough information to come back and get the vaccine at that time, that they're able to do so. Because we believe it's just that important to make sure that people are comfortable with making the right decision for themselves. Let me also say, finally, I've received the first dose of the vaccine. I'm fine. I have spoken to members of my community and members of my church. And I said, you know, it's okay if you want to wait and see a bit to see how those of us who got the vaccine first do. I'm doing fine. I'm not having any side effects at all. I look forward to getting the second dose next week. Let me close by saying that my sincere belief is that knowledge is power and that providing information about vaccines will build the trust and alleviate the hesitancy that many people may have. Right now, our communities of color suffer disproportionately from this pandemic. I stand with this community and with our city's leaders The University of Maryland medical system stands with our community and our city's leaders, and we are committed to building trust in the vaccine so that we can turn the tide in our fight against COVID-19. Thank you, Madam Chair.
Thank you, Dr. Gordine. Thank you for your transparency, and thanks for sharing this information. We're going to move to Dr. Destiny Simone Ramjon with CareFirst.
Thank you, Madam Chair, and greetings to the council, to the public, and our partners who spoke before me. I am Destiny Simone Ramjon, Vice President of Community Health and Social Impact with CareFirst, and I'm here to share more about our role in promoting a safe, effective, and affordable vaccine that has the public's trust through robust communication and education campaigns, comprehensive data management, and addressing the social determinants of health. I want to note that throughout the COVID pandemic, CareFirst has taken numerous actions to support the health and safety of our members, our providers, and the communities we serve. This includes a range of activities, including delivering care packages, waiving member cost share for COVID-related care, accelerating payments to healthcare providers, and committing resources for personal protective equipment to federally qualified health centers and small primary care providers. Through multiple channels, we've also prioritized member education and provided up-to-date developments related to virus safety, including prevention measures, limitations of antibody testing, and really the importance of keeping up with preventive care, immunizations, flu shots, and more. And really, those are the very same principles that we intend to take to support vaccine distribution. CareFirst is 100% committed to supporting broad and equitable allocation and distribution strategies that prioritize those at risk, most at risk for contracting COVID. So while the safe, affordable vaccine that has the public's trust is a key component to overcoming the pandemic, we also know that the public's appetite for a COVID-19 vaccine has waned significantly. You have seen, I have seen the Pew Research Center data, the Kaiser Family Foundation data, noting the number of people that state that they would get the vaccine is just north of 50%. How many of us have uncles and aunts and grandmothers that are just not ready? How many times have we heard from our family, oh, I'll wait until the next round? Vaccine availability is only beneficial to our communities if we can get shots in arms, so to speak. So there definitely is a clear opportunity for us to join forces with other carriers, healthcare and professional organizations, state and local governments to promote confidence and adoption. And we think that three things must be true in order for us to build public trust. The first is purposeful prioritization. As I and other speakers have mentioned, we believe that those most at risk for contracting COVID, prioritizing essential frontline workers, the elderly, people of color, and other vulnerable populations is mandatory. Certainly a racial ethnic disparities lens, as we've heard from others, ensuring that we support inclusion of equity as a cross-cutting consideration, not just in the 1A and 1B, but all the way through each of the phases for allocation recommendations and more. We can't lose sight of equity throughout this process. We also are doing our part, ensuring that there should be $0 cost sharing for the vaccination and supporting efforts that provide free access for the uninsured, who obviously are disproportionately communities of color. Third is this robust communications campaign. We support federal and state public communication and outreach efforts that build public trust, that address vaccine hesitancy. And effective communications campaigns need to have certain conditions, right? We have to take this approach that includes eliminating barriers to immunization, right? Dispelling myths, meeting patients where they are to address their concerns, and supporting uptake when the vaccine is widely available. But it also means that we have to look at the systemic approach, right? We have to collaborate with physicians to educate them as well as community groups on the clinical efficacy and safety data. But that also means that the vaccine is not the sole solution, right? We also have to think about proactive adherence efforts, things like maintaining your annual flu vaccination to reduce burden on the healthcare system. Let me talk a little bit about the work that CareFirst is unfolding in each of those three areas, including kind of what I would say is the information phase, fostering public confidence, right? That includes clarifying our coverage stance. CareFirst members will pay $0 for any authorized COVID vaccine. And then we're obviously supporting CDC guidelines, wear a mask, wash your hands, practice social distancing. On the education phase side of things and kind of working to dispel myths, that includes that we want to ensure that we're promoting personal, family, and community benefits of getting vaccinated, linking community perspectives and voices, both with the subnational and kind of this national policy dialogue. We know that Dr. Kizzy and Dr. Fauci are in high demand, and Dr. Freeman Harbowski, right? But that also means that we need to reach out to grassroots organizations, the Brittany Youngs of the world and more, the Darren Walkers of the world, the Michael Scotts of the world, Baltimore City influencers, the healing, Troy Statons of the world, folks that are really trusted on the ground from a hyper-local sense that build the self-esteem and confidence of care providers, adolescents, children, adults, and you name it. I want to also note that when we think about the activation phase, when the vaccine is broadly available, CareFirst will execute targeted communications that continue to address the concerns of communities disproportionately affected by the pandemic and related vaccine hesitant populations. I want to mention what we're doing by audience. So we're taking a few actions for communities. We'll be launching a wide-ranging campaign called Better Together around the region here to help educate and encourage people living throughout Maryland, the district, and Northern Virginia about taking the vaccine when eligible. The campaign will focus on the steps that people can take to help themselves break free from this unrelenting grip. It starts with knowledge, then we move to skills, then we move to attitudes, right? And so for the public health experts on the phone, you know that we're trying to ensure that our targeted communications meet populations where they are, and then obviously move them towards action. I've mentioned previously our robust data campaign. Later this week, we'll be unveiling a dashboard that will track vaccination adoption rates alongside social determinants of health measures, including socioeconomic status, gender, and geo-targeted data for flu and related COVID vaccine adoption. So the tool is going to be able to help map the prevalence of COVID cases, deaths, and positivity rates across the region. But we hope that armed with that information, individuals and the public will be able to geo-target more specific intervention opportunities. For our providers, our Care Delivered initiative will continue to distribute personal protective equipment at no cost to healthcare and social service organizations. The PPE, which is FDA approved and authorized for use by healthcare personnel, has distributed here in Baltimore City alone over 100,000 units of gowns, gloves, face shields, masks, and more to 41 organizations, including Associated Catholic Charities, Turk House, Healthcare for the Homeless, and more. So I think I want to close by talking about the social determinants of health, things that were exacerbated by COVID-19, but certainly will be here after COVID-19 and were here prior to the pandemic. 1 in 735 Black Americans have died from COVID-19 as of January 8th. Multiple factors have been implicated in this devastating human toll, including that Black Americans are more burdened by chronic diseases, more often frontline workers, more pressed into overcrowded housing, more pressed into low-income industries. And so really those social determinants, in addition to clinical care, is where CareFirst philanthropic and mission-driven efforts will also show up. These social, economic, and environmental factors cut across a wide range of interrelated upstream issues, including economic stability, education, especially closing gaps in the digital divide, food security, social cohesion, and much more. So in order to propel our vision of returning back to whatever this new normal becomes, CareFirst will continue to emphasize key social determinants of health to ensure a holistic approach to care. We want to be difference makers in partnership with you and our communities, and believe that this holistic approach will accelerate that charge. Thank you.
Thank you, Dr. Ramjan. For every panelist, I just want to extend an additional thanks. So thank you to Dr. Gordine, thank you to Dr. Golden, to Dr. Jaraza, and again to Dr. Ramjan. We're going to move into questions. I do have a few questions that we'll start with for other members of the council who have joined on. I will be letting our committee members who have questions get their questions answered first, and then we'll move on to you for our committee members. When we do get to, after I ask my questions, I'm just asking you that you limit your initial questions to 2, and then we will circle back through. And for my question, this is going to be towards Dr. Jaraza, and thanks for hanging in there. There's been a lot of public discussion locally and across the state about issues with the state rollout and the appointment system. Has the city encountered any of these issues? And is the health department getting the appropriate supply of vaccine from the state needed?
Yeah, thank you for that, Madam Chair. So the first question around the issues related to PrEP bond, which is the state's registration system, we have had challenges with the system. Again, speaking to a little bit around equity, obviously we know the fact that it's an online system creates issues with access to certain populations. So that's one challenge, right? It's a hindrance when we think about doing this in an equitable way. And then on site, as we're using the systems, there have been issues with being able to cap the number of appointments, so that we've seen overbooking, we've seen cancellations occur. And again, I think on the front end to the user, it doesn't appear that we're kind of overbooked, but on the back end, we know that we are. And so we've had to kind of adjust and make accommodations. Likewise, sometimes on site, we have to use that same system when we're actually at the vaccination site. We have had the system go down intermittently and have had to convert to paper in those instances. We've not slowed down our throughput, but it is a hindrance as a result. And then I'm sorry, what was the second part of your question?
The second part of the question is the health department getting the appropriate supply of vaccine from the state that's needed?
Yeah, so we are able to make requests on a weekly basis. So we can request the weekly allocation based on what we know for planning purposes, either based on the number of appointments we would like to schedule, or based on how we like to disseminate to partners. Those requests are not always honored. Again, I think the state will let us know a few days ahead of delivery. But again, those requests are not always honored.
Thank you. I have another question, and then I'm going to move it on to my committee members, just to be respectful of time. What is the health department's play for peer-to-peer engagement to contact our seniors and other vulnerable populations? I think you spoke briefly about it within a presentation, but can you just give me some more information about that? Thank you.
Sure. So I mentioned our MAP call center, which was already a call center we had set up to support older adults. We've expanded that call center so that, again, we can actually do outreach to older adults who may be interested but don't have access or the ability to sign up for a vaccine. So we would pre-register them so they don't have to go through the online system. So we have been using our MAP call center. And I think Dr. Gordine mentioned, or maybe it was actually Dr. Golden, our plan to really go out to senior housing sites. So again, kind of using a mobile approach to getting to our seniors who would be challenged to go to a mass vaccination site.
I'm going to open the floor to my committee members. I'm just going to recognize you in the order that I've seen you. We're going to start with Councilman Mark Conway, and then we're going to go to Councilman James Torrance.
Thank you, Madam Chair. And I want to thank all the presenters, certainly for your leadership and clearly your thoughtfulness in how we tackle COVID as a city. You've actually addressed a number of my questions, so I want to thank you for that. One of my other questions has to do with the booster shot, the second shot. We know that for the two current vaccines that are out, Pfizer and Moderna, you require 2 shots to get the 94+% effectiveness. What steps are we taking to make sure that folks are coming back, that they're getting that second shot? What education can we do, and how are we thinking about tackling that problem? I know that's going to be a big issue, especially for hard to reach populations.
Yeah, so certainly at our mass vaccination sites, initially we were registering people on site for that second dose, and we're working with them. We'll send out a link to remind them of their registration and remind them of an upcoming appointment. Obviously, again, if we have cancellations, and we would look to do outreach. We've not yet begun second doses, but we know again that people are scheduled for those second doses. For our mobile efforts, the good thing is because we're actually going to those sites, we can do even more focused outreach when we go back to a site for that second dose.
Excellent, thank you. And then my second question is about myths about the vaccine. So my wife happens to be a doctor, and as such gets a ton of questions and also a ton of concerns. How are you managing myths about the vaccine? How can we as beacons in the community, as leaders in the community, help echo those messages about myths about the vaccines?
Yeah, that's a great question. I think a lot of it is forums like this. This is an example of us being able to share information broadly to the community that's interested. I mentioned, I think, our telephonic town halls, and those will be open. We'll allow older adults and individuals who hop on those calls to ask those questions. We're also, even for our department, doing internal town halls. We've been invited to do COVID vaccine town halls for other agencies and other organizations. We spoke at SEIU's at one of their town halls. But again, we've been invited by a number of organizations to do town halls. And so between myself and my chief medical officer, Dr. McDowell, we try to go to everything that we're invited to.
Thank you. And just a shameless plug. So tomorrow, the 4th District will be holding a town hall for which Dr. Zaraza will be there as well. So thank you for coming out. Thank you, Madam Chair.
Thank you, Councilman Conway. We're going to go to Councilman Torrance.
Thank you, Madam Chair, and thank you to the panelists for the wealth of knowledge that you provided this evening. I am extremely encouraged by the information that you shared, but also another shameless plug. I want to thank the health department for picking BCCC as its mass site. As you know, I reached out to you, Dr. Daraza, and I will say one thing: it was a great pick because of the transit-oriented nature of where the site is, but also the success that BCCC has been as a partner for testing as well. So I thank you for that leadership and recognizing the value of that site. One of the questions I do have is more related to the MAPS hotline. One of the things that we're experiencing is hearing that seniors are having wait times between 90 minutes and 3 hours. Is there any way that we as a council or as a community broadly can help with the registering of seniors and volunteering for that? Because I think that's one of the things we have to think about with equity. How can the community at large help out?
Thank you, Councilman. I actually have the Deputy Commissioner of Aging on the line, and she can provide additional information around how we can get additional support.
Hi, Councilman. This is Hyung Tan at the Health Department. Happy to expand our reach to older adults by engaging other partners to help address some of the digital divide that is needed there. I'm happy to talk offline with you on how to do that. And I know there are members on the council here that we're working with and partnering with to be able to expand access for older adults.
Thank you. As my next question, it comes down to, could you please go a little bit more in depth about the mobile response teams? I think the public would benefit greatly by that, more information on that.
Sure. So again, going back to just the concept of leveraging partnerships, we actually had a flu vaccine strategy in the late summer, fall, early winter of last year. And as a part of that, we implemented mobile vaccination teams. And so this was a partnership with pharmacies. So at the time, we were able to partner with pharmacies, and they would provide a mobile team to go to senior housing sites that we had identified, that we had already done outreach, and had been able to gauge interest ahead of time, to vaccinate on site at those senior housing sites. So we've been able to take lessons learned from that approach in the fall and really apply them to how we'll do mobile response teams for the COVID-19 vaccination, doing the same thing, the initial kind of legwork, outreach, and coordination ahead of time, that pre-registration ahead of time, alongside our healthcare partners. So again, we have hospital partners who have stood up mobile teams that would be able to support, but same concept of, again, pre-registration, providing that education and outreach ahead of time, and then going to those senior housing sites. And I will see if Deputy Commissioner Tan wants to add anything to that.
I think the only thing that we are going to add is that we're expanding our outreach to senior housing buildings and developing a mop-up strategy to assisted living facilities and nursing homes and congregate congregate sites, in addition to the senior buildings that Dr. Shiraza had mentioned. Learned a great deal through the pilot of the seasonal flu work, and we're excited to get that started shortly.
Thank you both for that. I would like to have a follow-up offline to see how my district can support, because we have a large number of senior buildings and would love to help with the outreach for that. Thank you.
Councilman Schleifer?
Yes, thank you very much, Madam Chair. So first off, Dr. Duraz, I want to thank you and your team for the excellent work you guys have been doing. I know you've had to pivot every day in a different direction based on the state and every other factor, but I just want to say, with all things considered, you guys have been doing an excellent job, and your team has gone above and beyond. And I know I've probably called them with 1,000 different questions from constituents over the past couple of weeks, as I'm sure my colleagues have done the same. So thank you for that. I also have a question for Dr. Golden as far as Hopkins is concerned, because I've gotten a lot of questions about that as well. So can you talk to the percentage of Hopkins employees that are currently have been vaccinated, that are eligible?
Sure. So the most updated number I heard is that we've done 22,000 doses of vaccine. The majority of them, we're actually now getting into our second doses, and then like sort of late people who were originally in 1A, B, and C that are getting their first doses now. So if you think about percentages of our healthcare workforce, there's about 45 to 50,000 employees. That's across all of Johns Hopkins Medicine, so not just in Baltimore. So that sort of tells us that there's still a portion of our workforce that is still trying to decide whether or not they want to get vaccinated. And those are the people that we're trying to reach. Because one of the things that we are concerned about is that the state is going to start shifting vaccine supply away from the healthcare system modes of delivery to more the community-based and public health modes of delivery. And so that's why we're trying to make sure we're reaching the very depths of our front line before that switch happens. We have a hospital, Sibley Hospital in the DC area. DC has already said that there are no more doses for healthcare workers, that they're all for patients and community. So that's one of the things we've been considering.
Well, I think that's pretty eye-opening. I did not know that's pretty alarming, though, that over 50% of workers within Hopkins Medicine has not, and I'm hoping it's not because they're not interested in it, because that would be sending a pretty shocking message across the world, considering Hopkins has been a leader in this COVID fight, and with the database and the data and the science.
Right.
I've also received calls from constituents who work in that system who have not had the opportunity to have been vaccinated yet, and who are interested in it. So that kind of makes me pivot to the next question regarding you were talking about the equity portion of how you guys are going about your vaccinations, and so the external stuff. So clearly, I mean, there's still a ways to go inside the Hopkins network, but
Right.
the external work you're doing, can you talk about the a little bit more about the equity and how that's being distributed, especially as it pertains to age? Because
Yes.
as we know from the data and the science, the older you are, essentially, the greater at risk you are. And so, can you talk about the equity in our seniors?
Yes.
And how you guys are operating? Thank you.
Yeah. So, and just to follow up on the first question, I do want to clarify that for some of us, so that's all of our employees, including, for example, basic science faculty. So if we think about just the healthcare workforce, we've the 20,000 is a lot of vaccinations, but still, you're right, it's not a whole workforce. And again, we're trying to make sure we're very clear on that vaccine request form, because it says if you are directly involved in patient care, so that's obvious, or if you're involved in clinical operations. So we have people that we realized didn't recognize that they are a critical part of clinical operations. So for example, if our whole access services team got COVID and disappeared, we could schedule no patient appointments and no follow-ups. So we've also had to re-educate our employees on what clinical operations are. So I would say there's about 400 new employees requesting vaccines every day still. So we are getting that message through. So that's the first thing. And then the second thing, so for the seniors who are, particularly those who are marginalized, so what we're doing is, we identified specific clinics that are for those marginalized communities. So, for example, there are 6 of them. We have our Bartlett HIV clinic and infectious disease clinic. We have our health staff internal medicine practice, which is at the Johns Hopkins Outpatient Center. We have the Beecham Geriatric Center that's over at Bayview Hospital. And you have to be 65 or over just to be in that clinic. There's a comprehensive care practice and another general internal medicine clinic over at Bayview, where a lot of our Latino community seeks their care. So I may be leaving some out, but the point is that, we looked at all of the clinics that care for those marginalized communities and who in those clinics are over the age of 65. So like we have all of those individuals over the age of 65 identified. And so now there's a targeted outreach to them so that when their ticket comes up, that if they have an active MyChart account and their ticket comes up and they haven't claimed it within about 5 or 6 days, they get a phone call. And then if they don't have an active MyChart account, when their ticket comes up, they get a phone call. So, we're actually streamlining a call center to be able to do outbound calls to those individuals because we recognize that technology is a challenge.
So on that, so what number of vaccines do you plan to do externally outside of the Hopkins network?
So it depends upon how many we get from the state. So, so one of the challenges that we've been having, probably very similar to what Dr. Draza has been experiencing, is that, from week to week, we are not certain what our allocation is going to be. So, I'm on the internal vaccine committee, and I can tell you that last Friday, we were on the phone at about 5 p.m. We did not know if we were going to have doses for Monday. And so apparently there was a phone call on a Saturday to our operations leadership. You guys are getting these doses. And so literally the team worked through the entire weekend to operationalize being able to distribute those doses starting on Monday. So those are some of the internal operational challenges that we are having that aren't clear to our surrounding community. And our marketing communications is actually trying to update our external facing communication to state this, because our ability to vaccinate our healthcare workforce, our patients and non-patients in our Johns Hopkins community is all dependent upon the allocation that we get. And so that's the challenge. So it could be 3,000 doses in a week. It could be 9,000 doses in a week. We all don't know. So we very quickly over weekends and on Mondays, reorganize our operations to get as many vaccines in arms as we can. But you can see the equity challenge there, right? Because you've got a 75-year-old, we're like, okay, we've got doses and now we've got to call them, and it may take 3 calls to reach that person. So that's why we're thinking about, we've got to make sure we have some set aside doses for those who may take longer to get reached, who want the vaccine, so that we still have it available for them. So that is our biggest challenge, is not knowing from the state how many doses we're going to get in a given week.
Right, and so the last thing I'll say on
So
that.
Councilman Schleifer, I'm just asking you if you can just hold your questions, just to be respectful of all colleagues. We want to make sure that we cycle through, so I'm going to come back to you. Next up is going to be Councilman Bullock, and then we're going to be moving to Councilwoman Felicia Porter. Again, colleagues, we're limiting ourselves to 2 questions. Your follow-up does count as your 2.
Thank you, Madam Chair. And I just want to say, really impressed by the panel we have here today. I'm looking at all these Black women, health professionals and scholars, and all of you have made mention of some of the disparities and some of the history of discrimination as well. A lot of you have talked about issues in terms of race and class and age, but I'm curious, given your perspective, how gender is playing into this and disparities you see as it relates to women being vaccinated, and also some information that's going out. So that's really to the whole panel, if you could answer that. And that's my only question.
Yeah, I don't think that we have seen gender.
I lost sound for a moment, so I'm not sure if that question was directed at me, Councilman Bullock.
It was to the whole panel. Again, we're looking at, the question was really around gender disparity. So in terms of the rollout of the vaccine and information as well.
No, that's a great question. We're definitely seeing gender disparities where far more women are getting vaccinated. Again, I think for my fellow clinicians, it is probably not surprising that women are a bit more invested in preventative care. But I think you raise a good point. We do have a couple of special populations that we're looking at, and young Black men is actually a part of that group. So we do have a young, one of our leads within the health department is focused on young Black men and getting them vaccinated. I think what will be extremely important is obviously the messenger. So really having messengers and people who look like me, right? I think that's important for all of us. So one of the other things we're working on, I didn't mention before, is having vaccine ambassadors, right? So knowing that obviously the health department has credibility, but there are also many in the community who have far more credibility and who people are far more apt to listen to around the vaccine. So we will have vaccine ambassadors as well who will help with messaging and can be very focused again on what we're seeing in terms of gender disparities.
Yeah, and I'll just add to that. One of the other things we're doing at Johns Hopkins Medicine. So my husband's also a physician, and so he actually got his shot before I did because he's more engaged in the front lines. And so I was really happy to see that he posted his picture on Facebook, right away, because he recognized the need to be an example for other Black men in the community that this is safe and this is what we should be doing to protect our families. And so I think that's really important. So one of the things that we're doing is, even in our videos that we're making of our employees, interviewing people, after they get their vaccine and asking them what is their why. We're making sure that we're including, men, women of different races, ethnicities, and everything, so that there's somebody in that's delivering a message for everybody. Because I think that's really important.
Thank you very much. I know there was, I think it was Dr. Ramjan talked about local influencers. So I think that could be very useful. So hearing about how you would go about doing that is very helpful too.
Absolutely. And I think my colleague said it best that, this kind of trusted ambassador, trusted influencer, we know that Black women take our health seriously, and that we then become the influencers to create better health outcomes among our partners and loved ones and more. And so a part of what we've been doing is using data analytics at the zip code level, at the census tract level, and more to identify patterns and populations. We've been connecting that, as my previous colleagues have talked about, to social media messages to be able to geo-target even at the block level. And then, given what we know about the landscape, landscape, really leaning on trusted influencers at the grassroots level to first create convenings and forums for them as influencers to describe what their challenges are. So creating space, dispelling myths, and holding ourselves accountable for looping back with feedback and information and more. We had a question earlier about what role can we play. I think even simple things like not using jargon, right? How many of us can describe what mRNA means, what immunity means, what antibody means, and more? So there's something to be said, not just for who we are speaking to, but how we are communicating with those populations. So I think the better we can do in creating access to information that is jargon-free, that puts it in simple, clear language that is responsive to what's being raised, I think we're better positioned to then activate the power of Black Girl Magic.
Thank you so much.
Councilwoman Porter.
Thank you. Thank you, Madam Chair. Following up on Dr. Ramjohn's point, I just wanted to, for the sake of the public, to define what herd immunity is in basic terms, and then also can members share how long we are expected for Baltimore City proper and Maryland to reach that goal of herd immunity. I think we have to be clear with the public about just expectations based on the vaccination shortages that you all have mentioned.
Thank you for that, Councilwoman Porter. So the timeline that we laid out this evening was a goal of 80% vaccination rate by February of 2022. We know it's a very ambitious goal, but studies have suggested that we need to have about 60 to 80% of herd immunity, which I'll describe in a moment, before we can return back to some semblance of normalcy. So I would say herd immunity in layman's term is when the majority of the population is immune or protected against a particular disease, right? So again, that 20%, even though they might not have been immunized, because the majority of the population is protected, there isn't really disease transmission. There's not spread because most people are protected against the disease.
Thank you for that. And I look forward to following up with each of you, particularly related to the compound prevention efforts for youth under age 18 as it relates to these vaccination efforts, and also scheduling of our shift workers. There was some mention of essential workers, and most of the industries listed on your vaccination plan are shift workers. And so I want to be cognizant of how we're doing our outreach related to our shift workers as well. So thank you. And youth and young adults, thank you. And thank you, Madam Chair.
Thank you, Councilwoman Porter, for your questions and your comments. We're going to move to a few members who've expressed that they have questions that are not on the committee, and then we're going to circle back and make sure that we get back to the committee members. So the first person is going to be Vice President Sharon Gray Middleton, and you will be followed by Councilwoman Odette Ramos.
Thank you, Madam Chair McCray. First of all, I share the same feelings as my colleagues. Just thank all of you on this panel for the work that you continue to do as we fight through this pandemic. And I apologize if you had mentioned the answer to this question, but I'd like you to elaborate more on of course, we've had several people within the city that that have contracted the disease. And of course, they want to get the vaccine as well. Is there do they get at the bottom of the line? Is there a process for people getting the vaccine that already are experiencing going through COVID?
So if they actively have COVID, they wouldn't get the vaccine. However, to your point, Even if you've had COVID, we still strongly recommend getting the vaccine. We think that there's some level of protection when you have the disease, but your protection level is much stronger and lasts longer if you actually get vaccinated against the disease. So it is still very much recommended for anyone who's had COVID in the past. As far as prioritization, which I think was the second part of your question, they would be prioritized similar to what we've laid out in the phases 1A, 1B, and 1C.
Okay. Thank you. It answered my question.
Councilwoman Ramos?
Thank you, Madam Chair, and thank you for having this hearing. I've learned a lot. Commissioner, I have convened a group in my district, the District 14 COVID vaccine work group is what we call it. We'll come up with some fancier name at some point. And the goal is really I'm an organizer, so we wanted to organize our communities and have people help with getting the right information out to the community, help manage expectations, which is one of your big messages this evening, but also be ready for when there's the tipping point, we have enough vaccines, with all the information, how to get it out, et cetera. And then also, working with some of our communities that have a lot of distrust for good reason in the vaccine. And so, we're going to be doing some phone banking to try to help people signing up. We're going to be doing some, door-to-door safely, which I'm excited about. And to get to mostly, actually, the biggest priority right at the moment is I have so many seniors aging in place. They are not in senior buildings. And so one of the ideas was, can we, if you're going to do a site at Stadium Place or at 3838 or 3939, can we also utilize and inform the neighbors around there to say, if you're 65 and up, that you can come to that spot. So just thinking about, I have 95-year-olds that I don't want to leave the house. And so how do we get the vaccine to them? And so that's one of the big issues that I have is not just the senior buildings, but all of my seniors aging in place. And so hopefully we'll work together on a strategy in addition to the work that we're doing in the 14th district, which, by the way, Jeff was great in coming to our meeting last night and giving us some information. And I'll have Dr. McDowell on my town hall next week. So I guess to talk a little bit about that, but it also dovetails with the similar issues around PrEP map, because some people, have been having trouble with even the sign-on PrEP map, and also don't actually want to give all that personal information. So those two pieces tie in together.
No, thank you for that. And thank you for the invitation to speak at your town hall. We're excited to provide additional education. I will let Deputy Commissioner Tan speak to this a bit more, but we recognize, as you mentioned, there are many older adults who are aging in place and are not necessarily in a senior housing site or a congregate living setting. So we will be working with nonprofits and community-based organizations to really engage that group. And again, as more vaccine becomes available, host clinics specific to older adults. And I'll see if Deputy Commissioner Tan wants to add anything.
Thank you, Commissioner, and good evening. Thank you for your question, Councilwoman. So I think Dr. Shiraza had hit it that we are hearing from our housing site partners that surrounding areas and nonprofits do want to be engaged in this process. That is our intent. We are going to host a series of community engagement meetings with our nonprofit partners to see how we can expand our reach outside of the senior housing buildings. We do recognize that is limited to older adults who are living in the senior housing buildings. And at the moment in our mobile sites, if older residents are living in that building or living around the surrounding area and they fall into the 1C group, we will vaccinate. We will vaccinate that individual in that area.
Thank you. And we can talk more about that. And then my second question was around the Latino community. We have been working with MEMA and others to come up with a strategy, because it's going to be a different strategy for those who have who not only speak a different language, but also have trust issues with the system, and obviously are some of the highest impacted. And so I don't know if Dr. Durazo, you want to talk a little bit more about some of those strategies that, the Spanish speakers and Latino population is all over the city now. It's not concentrated in one area. So I want to make that clear that this has got to be that citywide strategy as well.
Yeah, no, Councilwoman Ramos, thank you again for that question too. As a part of our special populations group, we do have a particular group that is focused on the Latinx population. So I mentioned the work around our flu strategy and how we focus on older adults. We also did significant outreach to our Latinx community, mostly working with community-based organizations that were already trusted. We also provide care in one of our clinics to many within the Latinx community. And so we were able to leverage our role as a care provider and trusted care provider in the community to be able to disseminate vaccine to this group. So again, we're working very closely through that Latinx kind of subgroup to make sure that our messaging is focused, but also to make sure that that's similar to how we've deployed kind of a mobile and focused strategy for senior housing, tailoring a strategy that will reach that population as well.
Thank you. Thank you, Madam Chair.
Thank you. We're going to move to Councilman Eric Costello, who will be followed by Councilman Christopher Burnett.
Thank you, Madam Chair. Dr. Durazo, just want to thank you for everything. Obviously, sharing your frustration with the speed at which the city has been given vaccinations by the state, but want to acknowledge all of your hard work and your senior team, especially in your coordination with our world-class healthcare institutions in Baltimore City, to do your very best to make some lemonade out of lemons here. So really appreciate all of your hard work and looking forward to continue working with you and sharing this information with the community. So thank you. Thank you, Madam Chair.
Thank you. Councilman Burnett? Okay, so we're going to, and I actually see a committee member, Councilman Dorsey. Do you have a question?
Madam Chair, I just wanted to echo Councilman Costello here just to say thank you so much for all of the really great work that's happening. I want to thank my colleagues for asking such great questions on top of basically all of my concerns being addressed up front by our really wonderful panel here. Thank you so much, everybody, for sharing your time with us this evening and just so much dedication. I just bet you all just love talking about COVID-19 so much at this point. I'm just glad to be here with you. Thank you.
Thank you so much, Councilman Dorsey. It looks like Councilman Burnett is back. Councilman Burnett, whenever you're ready.
Thank you. Sorry about that, Madam Chair. My only question is to say thank you to all of the staff. I know this has been incredibly difficult to
Councilman Burnett, we can't hear you, so I don't know if you want to turn off your video. Go live from there.
Can you hear me now?
Yes.
Is that better? Okay. So I just wanted to thank the staff at the health department for your incredibly hard work. And my only question was just, how are you all doing? How are you holding up? And what ways can we could be more supportive of you during this time? Because this has been very much a marathon for all of you.
Well, I appreciate that opportunity because it gives me a chance to thank my wonderful staff. Many of those that are supporting planning and implementation efforts are also on this call and have worked long days for multiple months now. So they are tired, I know. I'm trying to encourage all of us to take more time and rest. But I think that we're doing okay, all things considered, but appreciate you asking and appreciate the opportunity to thank them for all they're doing.
Thank you, Dr. Jaraza, and thank you, Councilman Burnett. We're going to start again, and we're just going to circle back. Committee members, we are going to be doing one question and one follow-up, if necessary at this point, before we move to public testimony. Also, just want to mention and just thank all of our panelists again, because one or two of our panelists may have to leave. They do have other scheduled engagements, and this is going a little over. So I just want to be respectful of time. My question is for you, Dr. Jaraza. You spoke that first objective, number one, was 80% vaccinated by 2022, and then you touched on it in another question for us. What led you to pick that specific date, or what led the health department to select that specific date of February 2022?
I think, and again, I have some team members on the call who may be able to provide even more specifics. I think some of it is based on what we know as far as how many vaccines we've been receiving, kind of what our current allocation has been to date, and over time what the population has been. But again, I might defer to my colleagues to talk a little bit more about that. I think we have. Actually, Assistant Commissioner Rebecca Deneen is on the line. One other thing, and we didn't talk about this really as much, is that our current vaccines are approved, again, Pfizer 16 and up, and then Moderna 18 and up. Right. So we've not yet taken into account, children being vaccinated as well. They are beginning clinical trials in children, but that is obviously another really important part of the population. And we don't anticipate having data on children for a few months. And so, again, they will be vaccinated at a later time. And again, I think maybe Assistant Commissioner is on the line if she's able to speak to that.
Hi, yes, sure. Thank you, Dr. Jaraza. Really what you said, we hope that, when you hear what the federal plan is for getting another 100 million doses by the end, by the fall, by the summer, that a lot of the vaccination can happen by the fall, but then you have the pediatric population, and we don't really know when it's going to be approved for those younger kids. So we put the timeline out to February 2022, but we have we're trying to follow as closely as possible the 100-day plan to get, a good, almost half the population as quickly vaccinated as possible. But we want to extend the timeline primarily because of the pediatric population.
Thank you. And thanks for mentioning the information about the clinical studies about the kids, so we know where we're at. That's something that we have not asked yet. I want to get back to Councilman Schleifer at this time. I know that you did have an additional question.
You can pass on me. Thank you.
Okay, thank you, Councilman. For any of our other committee members or council members who have additional questions at this point, you can just signal to me and I'm going to call on you. Great, Councilman Torrance.
Thank you, Madam Chair. Thank you to the panelists for still being here with us. One of the biggest questions I've gotten because of the research and the fact that there was emergency use authorization is understanding that this is, in terms of the research, that this is not a new vaccine, and that the vaccine is based off of prior research that was years and years in development. Could you guys speak to that so that people understand that this wasn't something that was just created in 2 months?
Yeah, thank you for that, Councilman. So as you mentioned, the technology behind this vaccine, using mRNA in the vaccine, is not a new technology. It's been studied for years. And even the process, I think we get similar questions. Even the process with the clinical trials were done in the same way clinical trials would normally be done. One of the differences is the vaccine was being produced in mass quantity as the trials were going on. So no shortcuts were taken necessarily. It's just that where we typically would wait until a clinical trial is done to begin production of the vaccine, it was being produced alongside the clinical trial in hopes that it would be efficacious, so that once it was through that phase of the clinical trials, we could more easily distribute it because we already had that volume developed.
Thank you. And thank you, Madam Chair.
Thank you. Councilman Conway?
Thank you, Madam Chair. I know you guys probably want to get going, but I have one quick question about the changes to the virus. We know there are 3 new variants that are now traveling around the world from UK, South Africa, and Brazil. As we think about our rollout now and our ability to contact those difficult to reach populations, how are we thinking about our response should we end up in this race with the new virus? Are we thinking about ways for follow-up after this initial touch? And what can we do to make sure that if, for instance, we needed a 3rd booster or something like that, we'd be prepared to do so if there's a variant that gets around this virus? Excuse me, this vaccine.
Yeah, that is a great question. I think it's probably things that are being thought about and talked about and researched at the federal level. Because the variants are still so new, I think we're still all learning and figuring out how they will play out as time goes on. What we do know is that the vaccines are thought to be effective against the British variant. So we do know, at least what we've heard, is that they are effective against the British variant. I think I would use this opportunity to say 2 things. One, virus mutations are common. So these are things that are common. I know it can be scary, it can be concerning, but this is not unique to the coronavirus. We see this with other viruses. And then the other thing that I would use is I would encourage everyone to continue to do all of the same protective measures that have protected us so far. We want to continue to keep those things in place, even with the new variants, right? So we want to continue to maintain that 6 feet of social distance. We want to continue wearing our mask over our nose and our mouth. We want to continue washing our hands and staying home if we're ill. And that will protect us against the current virus as well as variants.
Thank you, Dr. Thank you, Dr. Zaraza, and thank you, Madam Chair.
Thank you. Other council members, do you have any additional questions at this time? Okay. So at this time, we are going to be moving to public testimony. Our committee staff will call on members of the public who wish to testify. Members of the public, you will have 2 minutes each to provide your testimony. For those who signed in using a computer, please use the raise hand function to indicate that you wish to testify, and we will start with you. Next, we will go through all of the users who have called into the hearing. Attendees who called in cannot be identified who may not be able to be identified by name will be unmuted by the committee staff one by one. You will hear 2 beeps when you are unmuted. And if you wish to testify, please state your name at the beginning of your testimony. If a caller does not wish to provide testimony, you can simply say that you don't want to and not provide the testimony after the 2 beeps. For any speaker who is inaudible, you will be directed to call back. And at this time, our committee staff member, Matthew Peters, will take over for the public testimony.
Thank you, Madam Chair. This time, it does not look like we have any attendees with their hands raised. And it does not look like we have any callers either. If any attendees would like to testify but are having trouble finding the raise hand button, you can also use the chat function to send a message to the host or to everyone to let us know. Looks like we have Christine Layton.
Hi, this is Christine Layton. I'm Baltimore resident for close to 30 years, and was on actually Councilwoman Ramos's call the other night. And there was someone on the call who mentioned, was a person who was of a Medicare beneficiary. And he mentioned that after spending a tremendous amount of time trying to sign up for getting his own or rather a COVID shot, that he was taken aback because he was asked for his Medicare card number. And as someone who has, worked in public health in this kind of field, I thought that that was kind of fishy. And I'm aware that there are a lot of scams and stuff going on. And I wanted to see, first of all, whether or not anyone can address the issue of will Medicare beneficiaries or people with private insurance be expected to provide their health insurance information when they're signing up? And assuming that that's not supposed to be happening, what kind of outreach can we have so that elders understand what information that they should not have to be giving out so that they're not getting scammed or whatnot?
Yeah, no, thank you for that question. And I assume perhaps he was signing up using PrepMod, which is the state-supported site. So again, I think it will ask for that information. You actually don't have to provide it. I know it's tricky because you see it, and so you automatically want to provide it, but you actually don't have to provide it. Your insurance is not being charged, and so again, this is the state's registration system that we're using in order to get folks registered, but you don't have to provide it. It is not, we're not using that information to charge individuals. One thing I would like to maybe go back to, because we have talked about the timeline a bit for when we'd like to have everyone vaccinated in the February kind of 2022 and why we've set that. Again, I just want to reiterate that much of that will hinge on supply. So obviously we're seeing, the federal government indicating that supply and production will be ramped up. So that is certainly subject to change depending on the supply and a variety of factors. Thank you.
Madam Chair, I know that I'm not on the committee, but Ms. Layton was in my meeting. I just wanted to clarify that I think our colleague, my other constituent who was on the meeting, he signed up for Giant. And so obviously there might be some differences between the PrepMod and like Giant, Walgreens, and all of that. So if Dr. Terraza could address that, that'd be helpful.
That is a great question. So certainly for our healthcare partners, that may be questions that they ask because they would be looking to charge your insurance an administrative fee. So they're not necessarily charging you for the vaccine, but the administrative fee of their staff having to provide you, and do the actual service. So it is possible that other sites may ask for that information in order to charge your insurance for the administration portion. And again, my hospital colleagues may be able to speak to some of the differences with their registration as well.
Thank you. There are no other questions or testimony from the public, so that's going to conclude the public testimony. I want to thank you all for joining us this evening. Again, our panelists for the great information that you have shared. The committee will likely be holding additional hearings in the coming months to keep the community informed about vaccination efforts and progress in the city. And this hearing is now in recess.